Very good evening to all the members of the extracurricular nephrology group for joining this webinar. Special thanks to Dr. Georgie and Dr. Satish Balan sir and Dr. Jithin Kumar sir for discussing this topic amongst the key nephrologists. As we all know, in our day-to-day practice, IV iron is a core part of our therapy for treating the anemia of chronic disease, particularly iron deficiency anemia. And whether this treatment which is there with the IV iron, apart from its hypersensitivity reaction, does it causing more dangerous effect to our body or not? How its effect onto the FGF23, the phosphate aspect, and the bone-related aspect, we will learn today by the two eminent nephrologists over here, Dr. Jithin and Dr. Satish Malan sir. Zydus is very grateful for this opportunity given by the ECNG nephrologist group of the Kerala. So with this brief, I hand it over to Dr. Georgie Malan sir. Thank you, sir.
Thank you very much, Dr. Kaushal. And at the very outset, let me thank Sidus Life Science for giving us this platform to discuss today about the iron FGF23 current evidence and future. And also, I thank Himanshu for all the coordination and efforts he has put in. So, with this, I will introduce Sadish Balan and Jithin at the end of the legends presentation of the legends. As usual, we have the history in nephrology. True legends never die. Its legacy lives on. And when we talk about iron treatment, which is very, very important nowadays in the chronic kidney disease, as Dr. Kaushal mentioned, anemia is becoming a very detectable, correctable factor. And when we talk about the legends in the iron treatment, two names are very outstanding. First one is Thomas Sydenham, and the second is Dr. Pierre Bloch. These are the two people who are very much connected with this. And Thomas Sydenham is English physician. He is popularly known as the English Hippocrates, was among the first physicians to champion iron steel preparation. It was called a steel preparation for chlorosis, establishing one of the earliest clinical use of iron in the treatment of anemia. This was very way back in 1624 to 1689 this happened. After that, Pierre Bloch, in 1832, he introduced the pill in his name, Bloch's pill, and this marked the birth of standardized oral iron therapy and revolutionized the treatment of iron deficiency anemia. So after that, many people contributed, and when you look at the evolution of iron therapy to the clinical scenario, this is the various milestones. You will better appreciate it in this pictograph, which is given here. I had already circulated. Very much in the ancient time itself, the use of iron-rich foods and herbs were and natural minerals to treat weakness and anemia. In 17th century, it was Thomas Sydenham who recommended steel medicines, iron preparations for chlorosis. At that time, it was known as chlorosis. Anemia was known as chlorosis. And in the 19th century, the pill was introduced by Pierre Bloch, and he developed this pill, which was none other than ferrous carbonate, the first widely used iron preparation. After that, by 19th century, 1900, the introduction of the parenteral IV and IM preparations, iron dextran, and when we were all doing house residency and PG, this medicine was available. It had to be given under supervision because mild to moderate to even anaphylactic reactions used to occur with iron therapy. And iron deficiency was a big correction factor in the pregnancy, and it was widely used at that time. It was by 1950s to 1990 the development of safer IV iron formulation came. IV sucrose. We all started with that IV sucrose, ferric gluconate with better tolerability and safety. And the beginning of this century, we have the two big molecules. The new generations of IV ions allow higher single dose, fewer infusions, and rapid iron repletion with improved safety. Ferric carboxy maltose, popularly known as FCM, and ferric diisomaltose. So, with this, ladies and gentlemen, I have great pleasure in introducing Sadish Balan for today's talk. The topic will be on IV iron and FGF 23, current evidence and future. Sadish Balan doesn't need any introduction. He is a very active member of this group, a very great academician, and an excellent moderator, I should say. And may I request Sadish Balan to introduce the topic and to introduce Dr. Jithin S. Kumar, who is the speaker for today. Dr. Sadish Balan, please.
Thank you, sir, for the kind introduction. So, I think what we are going to discuss today is a very important topic of IV iron. I think anybody who is treating patients with CKD, or even for that matter, in most physicians, obstetricians, everybody is nowadays using IV iron as a shortcut therapy instead. But IV iron is not something that you can just give like oral iron. It has got its own problems and its own side effects, which we have to know and which every physician has to know. Also, the speed at which you can give, how fast you can give it, how often you can give it, and what are the dangers of IV iron. All these should be known. So I think there is these are all things we have to discuss, and also the strange phenomenon of hypophosphatemia, and that's also seen with IV iron. So these peculiarities of IV iron, I think it's a good topic for all of us to discuss, and also for us to renew our own knowledge about this subject. So I will ask Dr. Jithin. Jithin is, very academic, uh, next generation of nephrologists from Lakeshore Hospital, who has given us several talks in the past of outstanding academic quality. So I'll ask Jithin to come along and give us your talk on this, and then we can discuss the points one by one along with all the others in this forum. Over to Jithin.
Thank you, sir, for those kind words of introduction. So at the outset, let me thank Cyrus for this opportunity, as well as Extracorporeal Group and Dr. Jithin for this wonderful opportunity. And as already discussed, today the topic is of interest is on iron therapy in CKD, especially the parent iron, and I will be briefly touching upon the interaction with FGF23 and the complication associated with iron therapy. Well, hope is my slide visible?
Yes.
Yes, sir.
Right.
Okay. So going on to the topic, as you all know, anemia is a common complication in CKD patients, and most often we see that the cause of anemia is being an erythropoietin deficiency, which is seen in 90% of erythropoietin is produced in the kidneys, and this is usually seen in CKD stages 3 to 5. Now, other cause of CKD, anemia in CKD is iron deficiency, nutritional deficiencies like vitamin B12, folic acid. So, of the lot, iron deficiency is very important in CKD because of various reasons. So these are the proposed mechanisms of anemia. One is the erythropoietin deficiency, other is the iron deficiency, nutritional deficiency, the increased inflammation which is seen, and accelerated reduction, the destruction of the RBCs, and loss of blood's uremic toxin inhibiting the bone marrow. population. Now, diet usually contains around 10 to 20 milligrams of iron. Of this 10 to 20 milligrams, only 1 to 2 milligrams of iron is absorbed by the proximal part of the intestine, that's the duodenum enterocytes. And for this, once it is absorbed, it is transferred into the bloodstream by means of a transferrin, and the transferrin takes it to the bone marrow for erythropoiesis, and it may be stored in the liver and spleen as well as in the form of ferritin, and usually lose 1 to 2 milligram of iron per day by way of desquamation. So just this is a systemic iron trafficking, which is seen as already described. And the only way of the iron is recycled is by means of the macrophage, the macrophage causing destruction of senescent RBCs, recycling the iron. So this is the just a pictorial representation of the iron absorption from the intestine. So iron enters into the duodenal enterocyte by way of various transporters, and once it is inside the enterocyte, may be converted to ferritin, or it may come or exit out of the cell with the help of the exporter called ferroportin. So ferroportin is exporter which causes the iron to come out of the cell, and this is inhibited by hepcidin. So in CKD, what happens is that the increased inflammatory condition can cause an increase in hepcidin, and this hepcidin can block ferroportin, and this decreases the intestinal iron absorption and also release of stored iron from the macrophages. So what are the types of iron deficiency which you see in CKD? So classically what you see is the absolute iron deficiency, where you can see is the low iron stores, then the transferrin saturation less than 20%, or a ferritin less than 100 nanogram per ml in a non-dialysis CKD, or a ferritin less than 200 nanogram per ml in hemodialysis associated CKD. What is peculiar to CKD is in CKD patients is functional iron deficiency. Here, what happens is the iron stores may be adequate, but it is unavailable due to the inflammation or increased hepcidin. So what you see is that the ferritin levels may be normal or even elevated, but the TSAT levels may be low. So iron is stores are there, but it is not available for erythropoiesis. So how do you diagnose and evaluate for anemia in CKD patients or dialysis patient? So frequency for testing for patients without anemia, you measure hemoglobin at least every 3 months in patients who are CKD on hemodialysis or CKD on peritoneal dialysis. And for patients with anemia not being treated with ESA, measure hemoglobin at least every 3 months. So usually measure at least every 3 months. Patients who are dialysis who are on a ESA or recent change in dose, you may have to repeat it more often. And diagnosis is when the HB levels is less than 13 in males and less than 12 gram per deciliter in females. So what are the biomarkers which are used to assess the iron status? The classical traditional the biomarkers are the ferritin. Ferritin is a marker of iron storage. Then you got the transferrin saturation, which assess the available circulating iron. So these are the usual two markers which are commonly used to assess iron status. A ferritin less than 100 and TSAT less than 30%, usually significant iron deficiency. And there are other newer markers like the reticulocyte hemoglobin content, which shows the real the time marrow iron supply. So this is a reticulocyte hemoglobin content is hemoglobin content of the newly produced RBCs, and this reflects the iron availability to the bone marrow over the preceding 2 to 4 days. So this detects iron restricted erythropoiesis earlier than ferritin or transferrin saturation. And unlike ferritin, which is affected by the inflammation or TSAT, which has got a lot of biological variability, this doesn't have that much of a variability, and it is useful in ESA treated patient. So a reticular hemoglobin content of less than 29 suggests iron restricted erythropoiesis, but this is not widely available. Now, other is the percentage of hypochromic RBCs, which also gives an idea of functional iron deficiency. So this gives an idea of RBCs with very low hemoglobin content, and this is a sensitive marker of iron deficiency, and 6% usually suggest iron deficiency. This is also not widely available, but these are all functional markers of iron deficiency, which may be more used in the future. So these are the future biomarkers like hepcidin levels, then the erythropoietin levels, the ferritin index, etc. What are the options for treatment of anemia in CKD? So ESA therapy, then you've got the iron therapy. Iron therapy can be oral iron supplements or IV iron therapy, and patients may be treated with blood transfusion if required. So what are the rationales of iron supplementation? Now, iron supplementation is intended to assure that adequate iron stores for RBC production is met, and also to correct the iron deficiency and to prevent iron deficiency from developing in patients who are on erythropoietin stimulating agents. So let us look into the evolution of iron therapy for some supplementation. So oral iron therapy earlier, as sir mentioned, was the ferrous salts, the iron polysaccharide, heme iron polypeptides were the things which were available earlier. Now we got 2013, we got ferric citrates, and then something which supports the iron HIF poryl hydroxylase inhibitors. Again, the iron therapy, the earlier was iron dextran, which a lot of hypersensitive reaction. The newer kids on the block are the ferric carboxy maltose and moxitol, as well as iron isomaltoside. Now, what are the benefits and risk of supplementation? Now, iron supplementation is an essential tool for effective and efficient treatment of anemia in CKD. It can raise hemoglobin concentration without the need for ESA in some patients. And it can also reduce the ESA requirement in patients who need ESA treatment. And there are other benefits beyond the correction of anemia. And risk involved are intravenous iron supplementation is unphysiological and sometimes can result in infectious consequences, cardiovascular consequences, and other hypersensitive reactions. Whether to choose between oral and parenteral iron therapy depends upon the stage of CKD. Patients on dialysis are better managed with IV iron, and the oral iron, the intestinal absorption may be affected because of concomitant other medications, and because of constipating dyspepsia, bloating, the GI symptoms which this patient may be having. Again, the oral iron supplements, the pill burden may be another determinant factor. And the advantage is it can be conveniently administered at home, and it is relatively inexpensive. But IV iron, it's a parenteral administration, and the risk of hypersensitive reactions are there, and it may have to be administered by healthcare professional, and it may require frequent clinic visits. It requires more frequent, expensive, but it may correct iron more rapidly. So what does KDIGO 2025 has to tell about when to start iron? So as per KDIGO 2025 guidelines, so there is a clear guidelines where they say in patients with non-dialysis CKD or patients of peritoneal dialysis, you have to consider iron therapy when the ferritin levels are less than 100 nanogram per ml and transient saturation is between 1%. And in hemodialysis CKD, you have to initiate iron if the ferritin level is less than 500 nanogram per ml and the transient saturation is less than 30%. And they also say tell withhold iron if the ferritin is more than 700 and the T-set is more than 40% to avoid iron overload. Advantages of the oral iron being it is cheap, easy to administer, and there are no infusion reaction. Limitations because of poor absorption, the increased GI side effects, and slower response when compared to IV iron. So these are the various oral preparations which are available. The ferrous ascorbate, the ferrous fumarate, the ferrous gluconate, sulfate, and heme iron polypeptide and polysaccharide iron complexes. So the elemental iron content varies according to the preparation. The recently used preparations are heme iron polypeptide, which contains 11 milligrams, and the ferrous sulfate 60 milligrams. And with this, the usual dose is around 50 to 100 milligram elemental iron TID, and the side effects being GI side effects may be there, and you usually food can interfere with its absorption separate administration by 2 hours before or 4 hours after iron when you give other drugs. Now about IV iron, the IV iron is preferred in hemodialysis as well as ESA treated patients and those with very severe iron deficiency and those who have got oral iron intolerance. and when the rapid correction of hemoglobin is required. The advantage is it can bypass the gut absorption, and the hemoglobin response is fast, and the requirement of ESA is low. So what are the iron preparations which are available? So the first generation iron preparations were the iron dextran, the high molecular weight and low molecular weight. And then came the second generation, which was a ferric gluconate and iron sucrose. And the recent ones are the ferric carboxymaltose and iron isomaltoside, where rapid correction and with high doses can be given. So these iron preparations contain iron in a stable ferric state as a complex with a carbohydrate polymer, which is designed to release the iron slowly for iron transport and storage proteins in the body. Let us look into the first poll.
You have to mute your other.
Can you launch the?
Can we launch that poll, please? Yeah. So this is the first poll that we have. Which of the following IVN do you use in HT? It's just something in regarding the personal choice of iron which you're using. It's not related to any methods. Can you please mute everyone else? Please mute others. Yeah. So poll is started. Now you can, I think we would have answered by now, so you can close the poll and show the results. It's always nice to have some baseline. So I think most people are nowadays using ferric carboxymaltose. That seems very easy. And not many people are using iron isomaltoside. So I think there is a lot of, actually, if you look at it, there is a lot of evidence that carboxymaltose is one of the safest preparations. And I think most why people are still using iron sucrose, because it is the cheapest compared to all. So it works out, I think, financially better for the thing. But if money is not a concern, I think more people will be using ferric carboxymaltose as FCM as the primary source of IV iron. So just a few opinions I would like to take from some of the senior people here. Dr. Beena Unikrishnan, you are there? Beena? Jacob, sir, are you there?
Yeah, I've used both ferric carboxymaltose as well as iron sucrose, but personally I prefer iron sucrose because I've not had any problems with iron sucrose, to say so. I never had any side effects.
Okay, I think we're all used to iron sucrose for a long time, so that was one of the reasons. Unni sir, you're here, Unni sir. So nice, Unni sir.
Yeah, I've been using ferric FCM, carboxymaltose. And
so now you use
quite
mostly
happy.
FCM. Okay. I think that's a complete change from what this thing. Jayant, are you there, Jayant? Jayant is also not responding. Okay. Arun, are you there?
Yes, sir. So we are using ferric carboxymaltose 500 mg once in 2 months for all dialysis patients because the biosimilars are available with 600 rupees. So that we don't, dialysis technicians will not be taxed with giving every 2 weeks.
Okay, I think it's a good choice. So anyway, we find a multitude of there are people using iron sucrose and ferric carboxymaltose. Not many using iron derisomaltose or isomaltoside, whichever one to use. They changed the name from isomaltoside to derisomaltose for some reason. We don't know why. Some chemical reason, maybe, probably. I think, Jithin, you continue with your presentation. I can't hear you.
Not able to move the slide.
Yeah. Oh. You can just close it and relaunch it. That may be better.
Yeah, you can.
Yeah. Anyway, it's moved now. But your voice is not clear. We can't hear you.
Yes, I think I can.
Yeah, now it's okay. Yeah.
So going ahead, so the recent choice being ferric carboxymaltose, if cost is not a constraint. And let us look at the advantages of IV iron. One is it does not require long-term therapy, and you ensure complete bioavailability of the iron, and the GI side effects which are associated with oral iron is not there, and it replenishes iron quite faster and more completely than oral iron. Now, the various preparations of IV irons are available. The older preparations being the ferric gluconate, the iron dextran was the earlier preparation, which has got high hypersensory reaction. Then came the ferric gluconate, iron sucrose, the ferric carboxy maltose, and iron isomaltoside. Older iron preparations are quite affordable, but require the administrative test dose. Iron sucrose is safer option, which does not require test dose, but it cannot be used at higher doses. You may require multiple doses to replenish the iron stores. And this correction of total iron deficit may require multiple dose, and ferric carboxy maltose presents as a better option as it can be administered as a total dose infusion without the need for any test dose. So let's launch the second poll.
Yeah, I think this is a very important topic. Catalytic iron is actually what is the free iron which is presented. Can you please launch the poll? Yeah. So free iron which is released on infusion. And that is one of the greatest dangers of this IV iron therapy, because and in fact the safest ones are the old ones like Imferon and Jectofer, the original iron dextrans, which are very tightly bound. So all these IV ions are bound to a carbohydrate shell. The carbohydrate is different. The original one was iron dextran. The problem is that even though it is safe in terms of catalytic iron release, it is not safe in terms of side effects like anaphylaxis and all that thing. So here's the poll. You can see that. So whether it's ferric carboxymaltose, iron isomaltoside, or derisomaltose, whichever you want to say, iron sucrose, or ferric gluconate. Actually, the answer was there in Dr. Jithin's previous slide, in a way, if you had read it carefully. So I think close the poll and launch the results. So you can see there's a variety of responses. The thing is that it depends on how tightly the iron is bound to the carbohydrate shell. So I think if you saw the previous presentation, I think if you just see the previous slide, I think just show you the previous slide. Jithin, which
Can
you
you
had.
close the poll?
Yeah, close the poll.
Okay.
Yeah. Not this one. This one, yeah, this is the one. So you see here that the stability for ferric gluconate is low, iron sucrose is low, moderate, and for FCM and isomaltoside is quite high. So the thing is that the lowest one is the one that releases most catalytic iron. That's why ferric gluconate, only 125 milligrams is the maximum single dose. More than that, the amount of free iron is not acceptable. And iron sucrose is slightly better, but still it can give only 200 milligrams, not more than that. And you should not repeat for 1 week more than 200 milligrams. So whereas the other ones are highly stable, almost like the original iron dextran, so you can give much higher doses. So that's the key here. But you must imagine catalytic iron is very dangerous. If you don't know much about catalytic iron, you can read. There are a lot of publications by one of our forum members, Rajapurkar sir. He has published. You can just search for that and you can find it. Okay, Jithin, continue.
Thank you, sir. So let us look in the limitations of parenteral iron formulation. One is the iron dextran. It has got serious allergic reactions and anaphylaxis, and the highest risk of serious adverse effects is in iron dextran. And iron injection is painful, and you can stain the buttock and requires multiple injections. And in iron dextran, low molecule can also cause non-fatal some side effects, including allergic and as well as anaphylactic reaction. And the test dose is usually required, and long IV infusion time of 1 hour. And then sodium ferric gluconate, it is only approved for iron deficiency in CKD undergoing hemodialysis, receiving supplemental epoetin. It can be administered in low doses, associated with high labile free iron release. And multiple clinical visits are required. Iron sucrose again can be administered in low doses, and multiple clinical visits are required. And the iron isomaltoside contains highest amount of labile iron among the third generation of parental irons. So let us look into the ferric carboxymaltose, which is now commonly being used. So it is a type 1 robust ion. It is not associated with dextran-induced hypersensitivity, and there is low risk of hypersensitivity reaction or anaphylactic reactions with ferric carboxymaltose. And the ion is released from the covered shell slowly, avoiding toxicity as well as oxidative stress. And there is rapid correction of anemia and repletion of the iron stores. Test doses is not required. The infusion time is short, and it can be administered at much higher doses, around 500 to maximum 1000 gram, and fewer clinical visits are required. So mechanism of ferric carboxymaltose is intravenous administration of ferric carboxymaltose. It goes to macrophages in the liver, spleen, and bone marrow, remove the ferric carboxymaltose from the circulating plasma. And iron from the iron carbohydrate complex is released, and released iron is either taken by the ferritin or the serum transferrin, and the transferrin binds to transferrin receptors on the erythroblast in the bone marrow. And this provides iron for hemoglobin synthesis as well as maturation of the red blood cell. And the cumulative dose of repletion of iron using ferric carboxymaltose is determined based on the patient's body weight as well as the hemoglobin level, and it must not be exceeded. So it depends upon the hemoglobin level and the patient's body weight. For example, if the patient's hemoglobin level is less than 10 gram per deciliter, and with a body weight of below 35, the repletion dose is around 500 milligram, and between 35 to 70, a dose of 1,500 milligram, and more than 70, 2000 milligram may be required to replenish the iron stores. And if the HB is between 10 to 14, the doses the 500 milligram below 35, 1000 milligrams between 35 and 70, and more than 70, it is 1500. So based on the hemoglobin in patient's body weight, the dose changes. So I say maximum tolerated dose, a single dose of ferric carboxymaltose should not exceed 1000 milligram of iron per day or 15 milligram of iron per kilogram body weight, and do not administer 1000 milligram of iron more than once a week. Regarding the method of administration of iron sucrose is administered 200 milligram undiluted by slow IV injection over 2 to 5 minutes, or it may be diluted in 100 ml normal saline for over 15, but usually it is administered over 30 to 1, that means 1 hour, and administer 5 doses within 14 days period to replenish the iron stores. The total cumulative dosage administered will be 1000 milligram, and treatment may be repeated based on clinical response or the blood indices. And for ferric carboxymaltose, it can be administered either by injection or by infusion, or during a hemodialysis session undiluted directly into the venous limb of the dialyzer. It should not be administered by subcutaneous or intramuscular route, and it can be administered by intravenous injection using undiluted solution. So usually the dose should not exceed 1000 milligrams, and usually administered over 15 to 30 minutes. So regarding the dosing of iron in dialysis patients, so the maintenance strategy is usually the iron sucrose is given 50 to 100 milligram weekly, or you can give 100 200 milligram once in 2 weeks, and 100 milligram or every dialysis session for 10 doses for repletion of the iron stores. You maintain the proactive strategy where the ferritin level is kept below 700 and the TSAT less than 40. So let's just look into the third poll of the day. Can you launch the third poll?
Yeah, I think it's an interesting thing because a very specific type of reaction that occurs with IV iron is called the Fishbane reaction. So whether the Fishbane reaction is an anaphylactic reaction, complement-mediated reaction, type 3 hypersensitivity reaction, or due to pyrogens in the infusion or IV line. So which is the correct answer? So you can all submit your polls. We will wait some 10 to 15 seconds. See. Okay, then we can launch the poll. We can launch the results. I think the equally distributed among all four, except complemented is the least answer which is given here, which is actually the right answer is complement mediated, because what happens, the Fishbane reaction is the patient develops, once you start the infusion, they'll develop some flushing of the face, chest pain and tightness in the chest, and maybe some myalgias, and they'll feel anxious, a little tachycardia may be there. But this is not a very serious reaction. This is not anaphylaxis, It's actually known as complement associated pseudo-allergic reaction. So that's a CARP reaction or a fishbone reaction. So because what happens is that this iron which enters the body will stimulate complement anaphylatoxins like C3A and C5A. That is a transient synthesis, and therefore it causes, this complements will cause this type of reaction. It is not allergic, so it doesn't cause anaphylaxis, doesn't progress anaphylaxis. All you have to do is stop the infusion immediately, just reassure the patient not to panic, wait for some time, and then restart the infusion at a much slower pace. And it should be treatable that way. The only thing is that did not give steroids or antihistamines, because these are not effective, because this is not an allergic reaction. It is not mast cell mediated, it is complement mediated, and it is temporary and transient. It doesn't, and need not occur the second time also. So that's a fishbone type reactions, and of course almost exclusively the IV iron therapy. It doesn't occur at any other type of things. So this is a type of reaction you see commonly, not commonly in the sense that once in a while you see this type of reaction, and don't think that contraindicates future iron. Anaphylaxis, the patient develops hypotension, shock, breathlessness, wheezing, then it's an anaphylactic reaction. It is not a complement. That's a different thing. And that has to be treated aggressively, and that's a contraindication for IV iron therapy. So in the absence of hypotension and wheezing and other features of shock, then probably this is can be assured that it's a complement mediated reaction. Okay, Dr. Jithin.
Just highlighting one of the trials, that's a pivotal trial which has recently changed the dosing as well as the cutoff the management of IV iron therapy. So this the pivotal trial, they compared between proactive as well as reactive strategy. So the proactive, the iron sucrose was given 400 milligram, and the ferritin was kept around less than 700, and T-sat around 40%. And reactin, the reactive arm, ferritin was around 200 and T-sat less than 20%. The iron sucrose was given to maintain the ferritin more than 20, close to 20%. So what they found that those who had the proactive strategy were the higher ferritin levels, and the higher T saturation was maintained, had reduced major cardiovascular events, as reduced ESA use and reduced transfusion, as well as there was no increased infection risk in the pivotal trial. So currently the upper limit of the T-sat is 40%. So next, moving on to the fourth poll.
Okay, so this is also an important point. Hypophosphatemia. I think we have to discuss this in detail, but before that, a poll. Do you think hypophosphatemia due to IV iron is important consideration in CKD? So that is the thing, and I think all of us will know that FCM has been associated with hypophosphatemia. Mechanisms and all that I will discuss, but this is an important point. I think we can close the poll and launch the results. So 67% says yes. I think it's important in CKD. I think the key point here is in CKD. In CKD, I think we will come to that after the discussion. Jithin, continue with this.
Yeah, sure. So regarding about this, ferric carboxymaltose can sometimes in IV preparation can result in hypophosphatemia, and this is because it can cause increased intact FGF23, as well as there is this may result in renal phosphate wasting and hypophosphatemia, and with rarely with repeated dosing, osteomalacia also has been reported. Now, what are the risk factors for this hypophosphatemia? One is repeated ferric carboxymaltose doses, or those patients who have got a low baseline phosphate levels, transplant recipients, and those who are malnourished. So you have to monitor the phosphate if repeated high dose ferric carboxymaltose is being used. And how does the iron and FGF23? There is a newly interesting topic whether it's iron deficiency, iron and FGF23 interacts in various ways. So iron deficiency has been found to increase the FGF23 transcription, and the certain IV formulation like ferric carboxymaltose can increase intact FGF23, leading to hypophosphatemia. So the what you can see is in the figure that erythropoietin can stimulate the the FGF 23. Again, the rise in hepcidin, which is seen in chronic inflammation CKD, can increase FGF 23. And there is FGF 23 regulates the inflammatory response, iron status, and erythropoiesis, and blocking FGF 23 activity can rescue anemia and iron deficiency. This has been
There's
found in
some
mice.
echo coming out from
This
your.
can be.
Yeah, it's
Yeah.
better.
So this is a potentially new therapeutic strategy. So if I and the FGF23 can cause there is increased FGF23 which is seen in iron deficiency as well as when there is use of erythropoietin, and this can cause phosphaturia and hypophosphatemia. So iron deficiency causes that iron deficiency can the hypoxia inducible factor 1 beta stimulated, and this can result in increased the erythropoietin, and erythropoietin can cause the increased transcription of FGF23. So there is FGF23 levels tends to go up. Again, this ferric carboxymaltose and iron polymaltose can impair the cleavage of intact FGF23, rising the FGF23 levels, causing hypophosphatemia.
Yeah, so now before this, I think before we go to this poll, go back to the previous slide. Yeah, so I just want to talk about this. So the point is that this rise in FGF23 and everything occurs basically in patients who have normal renal function. Please stop the poll, please. Please stop the poll. Yeah. So it rise in FGF23 occurs in patients with normal renal function. In patients who have CKD, FGF23 is already high. So it's very unlikely that patients with CKD will have a major problem with FGF23 and hypophosphatemia. Even at the GFR of about 60, the FGF23 starts rising. It's at one of the earliest hormones to start rising in a low GFR. So the rise in FGF23 and hypophosphatemia is more likely in patients with normal renal function, especially in gynecology patients, obstetric patients, as well as patients with, like I think Dr. Jithin already said, malnutrition and post-renal transplant, because the kidney function is normal. So the answer to my question was CKD is probably not an important complication, hypophosphatemia. With that, I would like to ask the opinion of the crowd. Unni sir, are you there? Have you seen hypophosphatemia with...
I've not been lucky enough to see it as yet.
Yeah. In fact, to be frank, I have seen only one patient, and that was actually an obstetric patient who had received this, and she was very tired, and then we checked, and then because she had just received FCM, we asked to check the phosphorus and turned out to be low, but got easily corrected. Jacob sir, have you seen that? Dr. Jacob sir?
Yeah, I was not aware of it, but now that you have mentioned it, I'll start looking for it.
Okay, okay. Beena, Dr. Beena, are you there? Beena's not there, I think. Dr. Jyotipriya, are you there?
Yes, sir. Sir, because majority of my patients to whom I have given this IV iron is CKD patient. So I think in a way it was, even if hypophosphatemia had happened, it was beneficial only because hyperphosphatemia is the major issue we are facing. So
Absolutely.
I haven't noted any such low phosphorus so far, sir.
And I think Dr. Jayamina is here. Are she there? Jayamina, are you there?
Yeah, I'm here, sir. I'm here.
Oh, yes, yes. Oh, yeah. Have you seen hypophosphatemia?
No, sir. I haven't come across. I do use this
Yeah.
molecule a lot, but I haven't come across. Never a problem for me.
No, actually, I learned about this FCM because I had a presentation on FCM some 1 or 2 years ago, and then at the time we realized hypophosphatemia is probably, and I've been looking for that since. I've never seen a single patient hypophosphatemia except that one patient which I told you about. So it is not occurring in patient CKD. So the answer to that question actually no. But just to continue, Dr. Jayamina, what common reactions have you seen with IV iron?
So
have
the
you seen
reaction is
anaphylaxis?
basically, to IV iron, basically like ferric carboxymaltose, I've seen this flushing, chest tightness, but these complement-mediated reactions I have seen. But to iron sucrose, rarely they do develop anaphylactic reaction. But it's rare. It's not so common.
Yeah. Unni sir, have you seen any anaphylaxis to IV iron?
I have also seen only complement-mediated, what you described as complement-mediated. I've seen occasionally, but I've never seen an anaphylactic shock.
Arun, what about you?
Yes, sir. So most problem is that this complement mediator reaction, just labeling is that as an iron allergy and lifelong iron bar is
Avoid.
there. So yeah, that's a main problem you are facing.
Yeah, I think that's an important thing because not only that, the patients refuse to take IVN after that. One side or they say, no, I had a reaction, I won't take IVN. And they refuse, some of them, once you give them. And then even if you try to counsel them, some of the patients are very reluctant. So that also happens after this. Okay, I think continue. Jithin.
Going ahead.
So the next poll is coming up, no? The last poll.
Yeah.
Yeah.
Can you launch this poll? The last poll.
So I think we already discussed some of this, so you can answer that. Please launch the poll. Which of the following complications are most worrisome in CKD patients? Hypophosphatemia, anaphylaxis, allergic reactions, not amounting anaphylaxis, nothing so serious to fear in routine CKD care. So I think you can wait for 10 seconds. I think it should be an easy answer based on the discussion we just had. Okay, you can close the poll and launch the results. Yeah, I think many people fear anaphylaxis. But like we are all saying, anaphylaxis is extremely rare. And you can look at it like people like Oni sir, Jacob sir, they are not seen anaphylaxis. And after so many years of experience. So it's I don't think we have to fear anaphylaxis that much. So most likely the second best answer is probably the correct answer. There is nothing so serious to fear in CKD care. It's not really that dangerous. So whatever reactions you have, it can be easily managed. It's anaphylaxis extremely rare. I don't know. In fact, in one of the studies of iron ferric carbosum, they said that more than they had a 30,000 or 40,000 patient database without a single case of anaphylaxis. So that is the amount of safety that we have as far as anaphylaxis is concerned. Okay. So continue with your presentation, Jithin.
Like sir said, the anaphylaxis is quite rare. In fact, I had seen only one case 3 years
Again, some
back.
echoes there. So yeah.
Is it clear now?
Now it's better, yeah.
So I had only one case of anaphylaxis, that was to iron isomaltoside, that when we gave 1 gram over 30 minutes. So after that, I stopped giving that high dose. No, just sparing that.
Okay.
So regarding the contraindications of IV iron, one is known hypersensitivity to iron preparation or to any of its excipients, and anemia which is not attributed to iron deficiency, and evidence of iron overload or disturbance in iron utilization in pregnancy in the first trimester. So regarding the monitoring of iron therapy, commonly used parameters are hemoglobin. The hemoglobin usually increases 1 to 2 gram per deciliter over the 4 to 8 weeks. And then you monitor with the transient saturation ferritin. Transient saturation usually maintained around 20 to 40%, and ferritin usually around 100 to 700 nanogram per ml. And in non-dialysis CKD, the monitoring should be every 3 months, and hemodialysis patients every 3 months, PD patients also at least every 3 months, and withhold iron when the ferritin is more than 700 or TSAT more than 40%. And in patients who are on ferric carboxymaltase, you can monitor the baseline phosphate. And iron overload is also something which has to be kept in mind. Risk with excessive iron therapy when the ferritin is more than 700 to 800 and TSAT is more than 40 to 50%, and this can contribute to oxidative stress and tissue iron deposition. Many times the prescription gets carried forward, and when we check the iron biomarkers, you find that ferritin and TSAT is quite elevated. And a few words on iron therapy and HIF pH inhibitors. Now, this HIF pH inhibitors are new drugs which are available for treatment of anemia and CKD. So they can additional advantages. They can lower the hepcidin levels, and this may result in better iron mobilization. So the theoretically the IV iron requirement may come down when compared to the ESAs because of its lower hepcidin. And going to the future directions in treatment of iron therapy, so there is the growing interest, and there are a lot of research going on hepcidin antagonist, which may increase the iron mobilization, and then there are ferroportin agonists are also there, so that the iron gets better iron availability is there. And then there is a role of personalized iron therapy based on the newer biomarkers, so that a precision-based iron therapy can be given, and AI-based iron therapy is also the biomarker-guided iron replacement and integration with the HIF-porolyl hydroxylase inhibitors. So finally, concluding, the take-home messages are: one, iron is reasonable in early non-CKD, but but often ineffective. ION is a preferred modality in hemodialysis patients, and you don't rely on ferritin alone. Always interpret the saturation. And the pivotal trial has established proactive iron as a standard hemodialysis strategy. And ferric carboxy maltose associated with hypophosphatemia is increasingly being recognized and should be monitored. And you have to correct iron deficiency before you escalate erythropoietin doses. Thank you.
Yeah, thank you, Dr. Jithin. It was a very comprehensive presentation on IV iron and its complications and how to use IV iron. This thing.